हेलो गुड मॉर्निंग। मैं से डॉक्टर आर्यन और आज हम डिस्कस करेंगे मेडिसिन के एनिसेट के पास्ट ईयर क्वेश्चन पेपर। आइडेंटिफाई द करेक्ट organism drug to which it is intrinsically resistant pair. Aspergillus niger, voriconazole, Aspergillus fumigatus, Micafungi, Candida albicans, amphotericin B, Candida crucifluconazole. This one is the answer. Because here among the given options, the Candida fluconazole shows what the intrinsically resistant pair to the fluconazole. The primary or intrinsic resistance of Candida cruzi to azoles like the fluconazole, itaconazole is mediated through reduced susceptibility of the target enzyme to inhibition by this drug. However, improved susceptibility is seen with newer generation or the newer generation agents such as voriconazole. Life-threatening system infection caused by Candida and Aspergillus species are usually seen in the severely ill and immunocompromised patients such as HIV, chemotherapy, and induced neutropenia, and the transplant recipient are immunosuppressant. And the next question. A 45-year-old male patient presented with a history of bilateral lower limb weakness which progressed to his upper limb in a year. On examination, he had weakness in both lower limbs and a wasting in the left upper limb. Babinski's sign was positive and the deep tendon reflex were absent. He has no sensory loss or any autonomic dysfunction. What is the likely diagnosis? MS, ALS, GBS, and tropic spastic paralysis. Here the best answer is ALS because here the given clinical scenario of both upper motor neuron Babinski sign and lower motor neuron absent deep tendon reflex, wasting finding in absence of sensory loss and autonomic dysfunction points towards a diagnosis of what amyotrophic lateral sclerosis, ALS. Diagnosis. What is the ALS? Is a progressive motor neuron disease with a mutation in the gene encoding protein C9 or C9F72. C9 or F72. Here the C9 or F72. The open reading frame 72 or chromosome 9 is that the meaning of the C9 F72. And cytosolic enzymes SOD1 like the superoxide diaspartase RNA binding protein TDP43 encoded by the TAR DNA binding protein gene and fused of the sarcoma are located in liposarcoma FUS or TLS. And the LMN lower motor neuron finding fasciculation, muscle cramp, asymmetrical distal weakness, atrophy and bulbar palsy. And the pathological hallmarks of ALS is the death of the motor lower neurons, anterior horns in the spinal cord and cranial nerves innervate bulbar muscles. And the upper motor neuron, corticospinal neurons originated in layer 5 of motor cortex. At onset, ALS may involve only upper and lower motor neurons, but ultimately causes what the progressive loss of the both categorical motor neurons. Clinical feature like that the fasciculation, asymmetrical distal weakness, atrophy and bulbar palsy, and upper motor neuron finding spasticity, increased reflexes, flexor spasm, and pseudobulbar palsy. Next question. A newly diagnosed HIV patient presented with fever, cough, and hemoptysis. His sputum sample showed acid fast bacilli. What is the appropriate management for this patient? Start ART if CD4 less than 200. Start ART and then ATT after 2 weeks. Start ATT and then ART after 2 weeks. Start ATT and ART simultaneously. Here the best answer is the start ATT and then ART after 2 weeks. In an like the HIV patient with TB, start antitubercular therapy ATT first and then start antiretroviral therapy ART as soon as ATT is tolerated. between 2 weeks or and 2 months of the patient. This is done to avoid immune reconstruction inflammatory syndrome RIIS. Among persons living with HIV, with TB, meningitis, CRT should be delayed for at least 4 weeks and initiated within 8 weeks. After treatment of a TB meningitis is initiated, patient with HIV-related TB may experience a temporary paradoxical exacerbation of symptoms and radiographic manifestation of TB after starting ARTRIRIS. This occurs as a result of immune reconstitution due to the simultaneous administration of ART and ATT. Next question. A patient presented with sinusitis ulcerative lesion on the nasopharynx, nodular lesion with cavitation of the lungs and renal failure. Which of the following is the most useful investigation in the patient? Test of ANCA, biopsy to show granuloma, AFB staining of sputum, and BAL. Here the given patient has involved the upper respiratory tract, chronic sinusitis, ulceration on the where nasopharynx, lower respiratory tract, nodular lesion or lung cavitation. And kidney renal failure, which is suggestion of granulomatosis with polyangiitis, Wagner granulomatosis, and testing for cytoplasm ANCA or CNCA would be the most helpful investigation of the condition. Here the answer: test of CNCA. Granulomatosis with polyangiitis is a granulomatous and a necrotic vasculitis of the small arteries and veins that may affect upper respiratory tract, lower respiratory tract, kidneys. In upper respiratory tract, like this chronic sinusitis, serous otitis media due to the Eustachian tube blockage, nasal septal perforation, and mucosal ulceration on nasopharynx. In the lower respiratory tract, the presenting with curb hemoptysis and persistent pneumonitis, lung involvement appears as multiple bilateral nodular cavity infiltrate, kidneys, focal or segmental glomerulonephritis presenting with proteinuria, hematuria, and hypertension. If left untreated, it can lead to the rapidly progressive glomerulonephritis. Apart from these organs, it can also affect the eyes, skin region present the palpable purpura or the subcutaneous nodule, and here the if you take the lab investigation will show the anemia, leukocytosis, elevated ESR, and high titers of cytoplasmic ANCA, CNCA targeted against anti-proteinase 3, anti-PR3. The specificity of the positive PR3 ANCA for the Wagner is very high, especially in the presence of the active glomerulonephritis. Following treatment for PR3 ANCA, titers fall and subsequent rise in titers is predictive of relapse. Chest radiograph here what shows the multiple bilateral cavity nodules and pulmonary infiltration. If you take a diagnosis is the presence of necrotizing glomerulometavasculitis on biopsy. This finding is most commonly seen in tissue obtained from the lungs, upper airway, and skin, and really in the kidneys. Next question. A 50-year-old man suddenly developed a right-sided weakness and aphasia within 2 hours. His BP recorded was 160 by 110 mmHg and NCCT was clear. What is the next step in management? The correct answer is CT angiography to look for large vessel occlusion, because here the next step is management would be the CT angiography. NCCT and CT angiography must be done concurrently, because during the stroke evaluation, the given here the feature of hemiplegia and Fmge and a clear NCCT just suggests to of the acute ischemic stroke and proximal large vessel occlusion. Therefore, the patient should be taken up the CT angiography. It has been high accuracy of the evaluation of the large vessels on occlusion. If the CT angiography determines there is a large vessel occlusion, ELVO, and can be used to the triage patient for management of arterial mechanical thrombectomy using a retrovirus device. Through thrombolysis is the treatment of the choice. Occlusion in a large vessel often fail to open up the thrombolysis alone. And hence here the mechanical thrombectomy is also indicated and should be done ideally within 6 hours. Done within 6 hours and not beyond 24 hours. Not beyond 24 hours of symptom onset. Next question. Which of the following is not a major diagnostic criterion for the neuromyelitic optica? Area of posthumous syndrome, acute myelitis, focal epilepsy, and optic neuritis. The focal epilepsy is not considered a major diagnostic criteria of neuromyelitis optica. NMO. Neuromyelitis optica is a Devick's disease. Devick's disease is a aggressive inflammatory demyelinating disorder characterized by recurrent attacks of optic neuritis and myelinitis. It is associated with a highly specific auto antibody directed against aquaporin 4 AQP4. AQP4 is localized where the foot process of histiocyte is close proximate to endothelial surface. The core clinical here the characteristics what include optic neuritis, acute myelitis, area posterior syndrome. Area posterior syndrome means the unexplained hiccups or nausea or vomiting. Acute brainstorm syndrome, symptomatic narcolepsy or acute diencephalic clinical syndrome with neuromyelitis optica spectrum syndrome, NMOSD. NMOSD. Neuromyelitis optica spectrum disorders. Typical diencephalic MRI lesion and symptomatic cerebral syndrome of NMSOD. Typical brain lesion. If the attacks of optic neuritis are bilateral and severe in NMO, whereas the multiple sclerosis MS optic neuritis is usually unilateral. Is the unilateral progressive symptoms are not typical of NMO. Unlike is the MS, CSO finding is NMO, so higher pleocytosis with neutrophils and eosinophil in acute cases, and a rare occurrence of oligoclonal bands and distinguishing it from MS. Oligoclonal bands in NMOSD. Drug used for the prophylaxis against relapse include mycophenolate, mofilate. Which drugs used? First, rituximab, mycophenolate, mofetil, glucocorticoids, and azathioprine. 3 monoclonal antibodies approved for attack prevention include eculizumab, inebilizumab, and satralizumab. And NMO typically prevent a recurrent disease with a monophagic course observed in less than 13% of the patient. Untreated NMO can lead to disability include respiratory failure, blindness, and limb paralysis. Which is the 3 monoclonal approved antibodies for attack prevention. Isluजुमैब क्या है? टर्मिनल कॉम्प्लीमेंट इनहिबिटर एंड सेकेंड इनबिलीजुमैब क्या है? बीटा सेल डिप्लीटर एंड थर्ड सट्रालीजुमैब क्या है? IL-6 रिसेप्टर ब्लॉकर. तो 3 एंटीबॉडीज है. कौन कौन से? इसोलीजुमैब एंड इनबुलीजुमैब एंड सट्रालीजुमैब क्या है? IL-6 रिसेप्टर ब्लॉकर है. और इनबिलीजुमैब क्या है? बीटा सेल डिप्लीटर. और इसलीजुमैब टर्मिनल कॉम्प्लीमेंट इनहिबिटर. So thank you and keep revising.